Welcome to the video series Cardiovascular Crisis, Caring for the Stroke Patient. My name is Kendra Menzies, and I'm going to present the program Cardioembolic Strokes, Atrial Fib. And this is a production of the Med-Ed seminars. Before we actually get started in the next module, I'd like to go again over your screen with you. In your upper left corner of your computer screen, you'll see an area that says Ask. If you have any questions about the material or would like to email me, you can use that button to send an email through Med-Ed, and they will get the email to me. If you want to open your handout, the lower left area will have a link, and that is the link to your handout. All right, so let's take a look at the next module, and the next module is Cardioembolic Strokes, Atrial Fibrillation. If you look at your cardioembolic stroke statistics, okay, and remember with cardioembolic strokes, this is where you have a clot that originates outside of the cerebral vasculature and gets thrown through the, let's say through the heart, from the left atrium, left ventricle, out into the cerebral circulation, and then it embeds up into a smaller vessel, and they lose flow distal, and they get an ischemic injury. So if you look at your history, your prevalence, or your statistics, we'll see cardioembolic strokes account for about 1/5 of the ischemic strokes. So the majority of your ischemic strokes are thrombotic. All right, so you've got about 1/5 of the ischemic strokes are going to be cardioembolic. Cardiogenic emboli are one of the most preventable ischemic strokes if the cardiac condition is recognized before the stroke actually occurs. So if you think about some of your risk factors for a thrombotic stroke, are not always modifiable. You know, we look at age, we look at gender, we look at racial differences. You know, they're not always modifiable. So they're not always as preventable. We know that aspirin can help, but we don't show significant improvements in preventing strokes with the use of aspirin if it's a thrombotic stroke. So if you look at an embolic stroke, though, if they identify that this patient has atrial fib, and they put them on some prophylaxis, which we'll talk about the Coumadin, then we've actually shown through studies there's a significant reduction in the risk of having a stroke. And that's what they mean by its most preventable ischemic stroke once we recognize the cardiac condition. The embolic material, and it doesn't necessarily even have to be a blood clot. It can be any material that is freely flowing through the vessel that can up into the arterial area and can actually occlude flow distal. So if you think about these embolic material, they can originate from different sources. You might have cholesterol fragments. We may have platelets and fibrin fragments that are actually occluding flow through the arterial vessel. Tumor particles are bacterial clusters. All right, so what we think of the most is a clot. But just keep in mind it can be any of these fragments or debris that is traveling freely that can embed up into a distal artery and occlude flow distal. And of course the most common cause of cardioembolic strokes is atrial fibrillation. All right, that is the most common arrhythmia that actually affects the general population as well. So there are about 1.8 million people in the United States that have atrial fibrillation. And again, remember they are high risk for strokes, so it's being able to recognize the condition and manage it. The prevalence of atrial fib, you know, how many people actually have it, increase as the age increases. So again, over the age of 65, we see an increase in atrial fib, and then it's found in greater than 1/3 of the patients that are over the age of 70 that have had ischemic strokes. Again, so it's a very high risk, it's a very prevalent arrhythmia, and we see it more in the older population. We also see that atrial fib is more equally distributed between men and women. So again, like in the thrombotic strokes we talked about earlier, we see a higher incidence in the male population. In your cardioembolic, with your atrial fib, we actually see it's a little bit more evenly distributed between men and women. Atrial fib, again, is typically the big cause of your large middle cerebral artery infarcts, strokes. And those middle cerebral artery infarcts, or the strokes, are associated with a high mortality rate within the first 30 days. And if you look at your anatomy of why we see most of the times the these embolic strokes result in middle cerebral artery involvement, and it's because of the way the middle cerebral artery actually just branches right off of the carotid artery, so that you have the carotid artery flowing directly into the MCA. And so if there's a clot or debris that is leaving from the heart and traveling up into the cerebral circulation, it's more likely to travel through the MCA, and so we see MCA involvement of the territory with strokes with that. Most of your embolic strokes are given by the thrombus, and that thrombus is because the left atrium doesn't pump on a regular basis, it does more of a fibrillation. All right, what you'll see is that because it's not pumping, the blood is tending to sit in that left atrium, and of course when blood sits, it clots. So when you see the clotting of the blood, they get these little clots sitting in that left atrium. That left atrium, they can throw that clot out into the cerebral circulation. The combination of atrial fib with other high-risk factors has also been shown to have a higher incidence of these embolic strokes than just having lone atrial fib alone. So we do talk about other risk factors here in a minute that may play a role on whether somebody forms a clot and whether that clot is actually thrown out as a microemboli. Embolic events may actually be intermittent and sometimes even years apart. So that if somebody has thrown a clot and we manage them, they may not be at a high risk for throwing a clot again in the next year. It may be years down the road before you see another incidence of their embolic stroke. So we haven't seen the follow-up that they've had them, like every year or within a 6-month period they're a higher risk. It's actually very intermittent, and it may be years apart before we see a reoccurring stroke from a cardioembolic episode. Now, like I said, there are other predictors. We know atrial fib is a high risk. We know that's probably the biggest reason we see thrombus and see the thrombi being thrown. But we also know there's other predictors of strokes from atrial fib. Some of these are what they call consistent independent predictors, meaning that if you look at all the studies, they're consistently been found as an independent predictor of a cardioembolic stroke in a patient with atrial fib. All right, so this is the listing that you have for those. So age, again, over the age of 65, and that increases even more over the age of 75. All right, so age plays a role in prevalence of cardioembolic strokes. History of hypertension. All right, if they have a history of hypertension, they're more likely to have a cardioembolic stroke. If they've had prior ischemic strokes or transient ischemic attacks, your TIAs, then again, that history, even if it's a thrombotic stroke, might put them at a higher risk for a cardioembolic stroke. And then any history of left ventricular dysfunction. So patients that have histories of CHF, that are left ventricular dysfunction CHFs, in addition to their atrial fib, is going to put them at a higher category or higher risk for the cardioembolic strokes. There's other lists that are out there, what they call possible independent predictors of cardioembolic strokes, meaning that these predictors or these risk factors have appeared in some studies but not as consistently as the previous ones we just reviewed. All right, so they do appear, they do seem to be independent risk factors, and again we'll go combination with atrial fib to predict those patients who get a cardioembolic stroke. And what's in this list is your diabetic patients, or so diabetes, systolic blood pressure is again at greater than 160. Women in particular over the age of 75. History of coronary artery disease or prior MI. Or somebody has a transesophageal echo that finds the appendage, that there's some thrombi up in the appendages. All right, so those are some of the other ones that we'll look at. Not independently predictive but has been discussed is the left atrium diameter. The larger the diameter, the more likely, or the prevalence. And then perioxysmal atrial fib. And again, that's all just being looked at and being discussed, but hasn't actually been found to be an independent predictor of having a cardioembolic stroke. And in fact, if we look at this perioxysmal, and now remember, perioxysmal atrial fib means kind of comes and goes. That if I hook somebody up on a monitor, I might find that they're in a normal sinus rhythm. And then a day later or 30 minutes later, I can watch their cardiac monitor and they start to have their episodes of atrial fib. So that's what we mean by perioxysmal. And the paroxysmal atrial fib has very similar underlying causes to your sustained atrial fib. So we see it a lot of times, again, in elderly, hypertension, history of congestive heart failure, post-op patients, post-CABG, post-valve replacements. All of those are higher risks for the atrial fib. Well, we see the same thing with paroxysmal that we do with sustained, and that is they have the same underlying causes. Of all of the atrial fib, paroxysmal atrial fibrillation actually accounts for about 25 to 60% of all the cases. Now here's where the controversy lies, and this is why we said it was not in that independent predictor, and that is the risk of the cardioembolic stroke with a paroxysmal versus a sustained. And right now what it looks like is that the risk may be lower in a patient who has paroxysmal atrial fib than those who have a sustained atrial fib. But the problem is that we say, okay, yeah, they're a lower risk. They don't need to be anticoagulated because of their risk as being not an independent risk factor. It's not a really high risk. So we don't need to give them anticoagulation therapy. Problem is we really don't always know their frequency, how often do they go into the atrial fib, or how long do they sustain that atrial fib. And that will vary based on the individual. So if we take that stand that it is not as high of a risk for cardioembolic stroke, so we're not going to anticoagulate them, and you happen to have a patient that will actually go into their atrial fib more often and sustain it longer, then they're going to be more in that category of a sustained. We don't know that. Puts them in a higher risk, and again, we miss that by not anticoagulating them. So that's been kind of the controversy or the debate, and that is, what do we do with these paroxysmal atrial fibs? Do we anticoagulate them or do we not? And currently, the recommendation is to treat these paroxysmal atrial fibs just like you treat the sustained atrial fibs. All right? So we're going to go over the management of these patients, but just keep in mind as we review the treatment, we're doing it for both the paroxysmal as well as the sustained. Stroke reoccurrences. We know the short-term risk after the short-term risk after the initial stroke is not well known. We know later on that again it becomes intermittent, it's very inconsistent, and it may be years before we see a reoccurrence. But the immediate period right after the first time they throw a clot, we don't have a lot of data to show what their risk is. There are currently 3 randomized trials that indicate the patients that are treated with aspirin at different doses and different times, but within the first 2 weeks following their stroke, had a recurrent risk of about 5%. Okay, so this was actually lower than they expected, because your expectation on these patients is that if they had a clot sitting in their atrium and they threw a piece of that clot out to the cerebral circulation, then we still have clot in there and it's still very prone to being thrown as an emboli. All right, so the expectation that in the initial period after the stroke, there might be a higher risk for actually throwing or reoccurring the stroke. And what they found was the recurrent risk was about a 5% within those 2 weeks. So that was actually, again, expected, was a little bit lower than what the study themselves expected. Stroke prevention. When we're looking cardioembolic stroke prevention, there have been randomized clinical trials that have verified the efficacy of your antithrombotics to prevent strokes. And what they have actually found is by putting somebody on these antithrombotics, that they can actually prevent the stroke by 60% compared to the untreated patient. Again, you have 2 groups of patients. One of them is placed with the antithrombotic, one is with a placebo, and they were able to reduce the strokes by 60%. And that is significant. I mean, we're not talking a slight reduction or a little bit of a difference between the 2 groups. Reducing a stroke risk by 60% with the use of antithrombotics is very significant in the way of outcomes on these patients. If you look again at some of the trials for stroke prevention, warfarin, Coumadin, was effective at preventing these disabling strokes by 59%, and they were also effective at decreasing the non-disabling strokes by 61%. So again, it's right in that 60% average range of preventing reoccurring strokes or preventing strokes that can either be disabling or non-disabling strokes. All right, so again, significant studies, significant support in the use of antithrombolytics in these patients who are in atrial fib. Primary prevention and secondary prevention. Let's talk about the difference between the two and what the terminology means. When we talk about primary prevention, what that means is this is in a patient that has actually not had a prior stroke. All right, they've got atrial fib, they may have some risk factors, but they've not had a cardioembolic stroke. That would be somebody now we're doing a primary prevention on. Secondary prevention is when we do prevention in a patient that has had a prior stroke. So this would be somebody who has actually had a prior cardioembolic stroke. We now know they have atrial fibrillation, and we're now looking at trying to prevent a reoccurring stroke. Okay, so there's two big categories of prevention. And it really, the recommendations in some of the studies have focused more on primary prevention, and some of them have focused more on the secondary prevention. So what we're going to take a look at when we look at these studies is a little bit of the difference between the two and what the recommendations are. The initial studies that I already addressed with you, when we talked about taking the warfarin and comparing it to a placebo and lowering their risk by 60%, those were done with primary prevention. Only one of the studies was secondary. All right, so most of the studies that I've reviewed at this time have been primary. So again, just having the atrial fib and putting them on the Coumadin, lowering their risk by 60%, that was in primary prevention. So secondary prevention studies, let's take a look at some of those. With your secondary prevention studies, again, using warfarin compared to a placebo, what they found is that warfarin reduced your cardioembolic ischemic strokes by 68% compared to the placebo. So again, the studies are still showing the same, that whether it's a primary or a secondary, warfarin has shown to be effective at preventing a secondary cardioembolic stroke. The absolute risk reduction of all strokes was about 3% per year in primary prevention, and the absolute risk reduction was about 6% per year for secondary prevention. So again, there may even be a little bit more effectiveness of the Coumadin in your secondary prevention. Now there are risks, all right, so anytime we talk about putting somebody in an anticoagulated state, anytime we talk about putting somebody on Coumadin, then of course we're looking at the risk of the bleed. So we always have to talk about a benefit versus a risk. And we know the benefit is there. Now let's address the risk of having a cerebral hemorrhage when we have somebody on the Coumadin. And what they found is that the risk for the major bleeding complications, which would be the intracerebral hemorrhage, was about 0.35 to 2% per year if you kept them in a target range, and we're going to talk about these INR ranges here in a minute, but if you kept them within the target range of 1.5 to 4.0. And if you kept them in that range, then your range for a bleed was about a 0.35 to a 2%. So again, risk versus benefit, it appears that there's a greater benefit in using the Coumadin than there is in the risk of having a cerebral hemorrhage. All right, so that's currently where we're at in looking at risk versus benefit. And those studies were looking at the Coumadin for prevention. They've also studied aspirin to see how effective aspirin is at preventing a cardioembolic stroke. That's a primary prevention. They've also looked at it as preventing recurring strokes as your secondary prevention. The doses of aspirin based on some of these studies have varied very greatly. Some studies used a dose of 50 milligrams all the way up to studies using 1,300 milligrams per day. All right, so again, there is a little bit of a range of the actual dose of the aspirin. What they showed in the way the efficacy for stroke reduction, it showed a 22% reduction with an absolute reduction of 1.5% per year for the primary prevention and a 2.5% per year for the secondary prevention. And again, this was all a pooled analysis. This was all using all these randomized studies and doing like a meta-analysis and pooling it all together. So if you look at your benefit, there is a benefit of using aspirin to prevent strokes, but the benefit doesn't appear to be as great of a benefit as warfarin. Okay, so that's the first thing you have to look at. Is remember, warfarin improved by about 60%, aspirin now by about 22%. But now look at your risk. If you look at your bleeding complications, your intercerebral hemorrhages, the risk on putting them on aspirin was about 0.2% per year. And that is definitely lower than what the Coumadin was. All right? So the benefit of aspirin may not be as good as the Coumadin, but the risk of the bleed is actually better in the aspirin versus the Coumadin. So when we start to get into recommendations, you'll see a lot of the recommendations depend upon the patient. You know, is the patient at risk for a bleed to begin with? You know, and if so, maybe aspirin would benefit them. Are they a high risk for a cardioembolic stroke? If so, then maybe Coumadin is going to be our best option. And that's why we do look at the two different studies on that. All right, so we will get into some of the recommendations in that area. Pooled analysis, there were actually 6 studies that directly compared your anticoagulants to aspirin. All right, so now these were studies that were directly comparing the two. And what they found is the anticoagulant group had lower risks for a stroke, but again, the higher risk for a bleed. So it was a 2% versus a 5% risk for an ischemic stroke, and it was a 2% versus a 1% risk for a bleed. Now, the article that I read on this pooled analysis, I kind of like the way they pulled it together and gave you numbers instead of just percentages. So that's kind of what I kind of jotted down for you at the bottom of the slide. But for example, all right, just to put this to a number, for example, 1,000 patients with atrial fib for 1 year with warfarin rather than aspirin would prevent 23 ischemic strokes. Okay, so if you take 1,000 patients for 1 year, put them on warfarin, what you would find is you would prevent 23 ischemic strokes, but you would also have 9 episodes of major bleeding. All right, and I think that's an easier way for me anyway to look at some of these statistics, so that there is an improvement in preventing strokes, but you also have the risk of having the cerebral hemorrhage on that. The secondary prevention efficacy actually depends a lot upon the underlying type of their ischemic stroke. We're going to talk a little bit about adjusted doses of warfarin based on their INR. But again, the warfarin appears to be more efficacious than aspirin, and a little bit less benefit than in the way of the bleeding. So all right, let's take a look at how we can stratify a patient's risk on whether we need to put them on like a Coumadin or an aspirin, or how the physicians make those decisions. So again, risk stratification, we've talked some about these in the way of their independent risk factors. If you have somebody who is a high risk, like a prior stroke, age greater than 75, history of hypertension, or left ventricular dysfunction, then that patient may actually be treated with, say, the Coumadin, all right, a higher risk for a stroke. Then you've got the moderate risks, which a lot of people put into that: coronary artery disease, thyrotoxicosis, age 60 to 65. And then the low risk, they put in a younger age, less than 65 years old. And actually we see quite a lot of people that are young that also have atrial fib. All right, so we do actually have quite a lot of people that sit in that less than 65 years of age with atrial fib, and we're looking at prevention. So high-risk patients are ones that are good candidates for the anticoagulation, so that we can minimize their risk of a stroke. Now, so as we say that, we say now we put them on warfarin, all right, because we've shown that it's better at preventing a stroke, but we don't want them to bleed. So it depends upon their risk stratification on how much we give and where do we want to put their INR at. All right. So let's take a look at the INR levels and how it relates to the risk stratification of the Coumadin. So for the first example, we can do what's called the low intensity anticoagulation, meaning giving the Coumadin just to keep their INR in a target range of 2.0 to 3.0. It's elevated, but there's only a slight elevation in that INR. All right, so it's kind of your lowest level of elevation by using anticoagulation. And what they found is effective in primary stroke prevention, and in somebody who has a lower risk. So, for example, if somebody is under the age of 65 years of age, no previous stroke, no cardioembolic stroke, no significant risk factors, then putting them on Coumadin is probably a good thing to do, but maybe not as high of an INR. Maybe keep their INR between that 2 and 3 so that it lowers their incidence of their risk of bleeding. If you have a high-risk patient, then what the studies have shown is that it may be more effective if we use higher INR targets, not that low level, but maybe putting the targets between, say, 3, all right, in a range of 3, at 3, or a range of, say, 2.5 to up to 4.2, all right? Now, that's a higher range, so it's more effective at preventing the cardioembolic strokes, but now it has a higher risk of a bleed. All right, but on a high-risk patient, that is kind of the recommendation, is do a little bit of a higher range and a little higher INR to be a little bit more effective. Now, there is some studies, again, that show that anytime you get greater than a 4 on your INR, then you are going to significantly increase your risk of bleeding. Okay, so the ranges that we've given you, anywhere from 2 to some studies, they even say up to 4.2. Keep in mind that the incidence significantly increases after 4. All right, it's going to go up incrementally as you go up on your INR, but it goes up even greater as it gets over 4. All right, so again, just some examples. All right, how do we use the warfarin with the INRs based on your patient? And these are just some examples. High-risk patient, under the age of 75, but a high-risk patient, we might put them an INR target of, say, 2.5 with a range of 2 to 3. And that would show to be more effective and safe for that set of patients. Say the patient is older than 75, then at that time, again, they have a higher bleeding risk. So in that patient, they may get a lower INR with a target range of 2 so that it minimizes their bleeding complications. Another example might be a patient who is younger than 60 that has what's called lone atrial fib, meaning that if they only have atrial fib as their risk factors. They don't have any other risk factors for cardioembolic stroke except the presence of atrial fib. So if they have what's called lone atrial fib and they're a low-risk patient, then they may not actually require long-term anticoagulation. This is a group that may actually benefit from an aspirin. All right, so that's where we may use aspirin alone as being an effective treatment with a less bleed risk. Okay, so if it's a lone atrial fib, patients under the age of 60, then it may just be an aspirin. So those are some of the examples of different patients that we may use the different INR target ranges on when we're administering their Coumadin. Other antithrombotic therapies have actually been researched. All right, so they have looked at a few other ones. Instead of just looking at Coumadin and aspirin, aspirin being the antiplatelet, they've also looked at direct thrombin inhibitors. All right, direct thrombin inhibitors. The SPORT-RIF3 study, all right, SPORT-RIF3 study looked at over 7,000 patients with atrial fib. They were randomized either into the adjusted dose of warfarin, where they put the INR between 2.0 and 3.0, or they randomized the patients into the fixed dose of the direct thrombin inhibitor. All right, so you either had them in the warfarin, putting the INRs between 2 and 3, or you had them in the direct thrombin inhibitor group, which is the experimental group. And what this SPORT-RIF study showed is that the experimental group had fewer strokes, had fewer systemic emboli than the warfarin group, and they also had lower bleed complications. So that, for example, it was a 1.6% versus a 2.3% per year stroke, which was about a 44% relative risk reduction. So direct thrombin inhibitors may actually be a drug that are going to be as effective, if not more effective, than Coumadin, and less complications. So there needs to be more studies now on these direct thrombin inhibitors to look for safety. All right, we've looked at some of the efficacy, which is what the SPORT-RIF3 study did, but now they need to look at a little bit on safety, and of course cost is going to play a role because it's a new drug. and Coumadin is relatively cheap. So what are the proposed benefits or advantages of these direct thrombin inhibitors? One of them is the fixed dose. You know, you think about if anybody's ever dealt with patients who is on warfarin, it takes a lot to get their INR within the range that you need it in. All right, I've done a little bit of home health nursing that I'll go out and draw their INR levels and make the adjustments in their dosings. And there's times you're doing this repeatedly throughout the next several months to try to get their INR to stabilize within the goal range or the target range that was ordered. So it's a lot of titrating. It's an up and down on the dosing versus the thrombin inhibitors, maybe a fixed dose. We know that there's a lot of food and drug interactions with your warfarin versus these direct thrombin inhibitors. They don't seem to have as much. So like if people on home on warfarin might add something or take away something, or and it's going to affect their clotting times. Let me give you the example I've got. This patient, like I said, I was doing some home health nursing on, and he was being anticoagulated for atrial fib. All right, he was on warfarin, and I came in and I draw an INR level, and it, you know, one time it'd be really high, and one time it'd be really low, and we'd done this now for going on a couple of months, trying to regulate his INR level into his target range. And I had done all the questionnaires on what do you eat, you know, what are your foods of choice, what did you eat, keep a diary for me, what are your drugs you're on. You know, I'd gone through all these potential possibilities that have had an interaction between the drugs and the food. Couldn't figure out why his INR kept bumping up and down. I mean, we just couldn't get control of it. Well, I had the advantage in this particular case of being in his home because it was home health nursing. So I was sitting in his kitchen, I was talking to him, and one day I looked over on the countertop and there's a bunch of herbal preparations, you know, supplemental nutrition on the countertop. And I looked at that and went, oh, when I asked you about your drugs, I didn't even think about the herb preparations. And so I said, give me a list of what you're taking and let me look up what might interact or be an anticoagulant that might interact with the Coumadin. And what I found was it was licorice. He was taking black licorice, and I don't remember why, but he was taking this black licorice, which has a side effect of an anticoagulant. He wasn't consistent on when he was taking it, so what was happening is it was interfering with the Coumadin, and the levels were going up and down like a roller coaster. So again, it's difficult. You know, you have to do frequent monitoring on their anticoagulation therapy, which means either home health or visits to the clinic, and there's a lot of things that interact. So there are some advantages to the direct thrombin inhibitor. Like I said, the proposed big disadvantage currently is the cost, all right, and because it's a newer drug. What other types of anticoagulation therapy can be used or have been looked at? One of them is heparin, and of course, and then we also look at the low molecular weight heparins. Heparin is one of the most common parental anticoagulants that we can use in these patients that have a known clot to stabilize the clot, or can be an atrial fib. And what heparin does is it binds to the antithrombin 3, which then inactivate factors like factors 2A and 10A. All right, so that we'll see that it binds and it inactivates some of the clotting factors so that it blocks or stops kind of the clotting cascade in these patients. The problem with heparin, all right, and I know that we know that when you're giving heparin, again, it's going to vary based on the patient's size. We can do a little bit of kilogram dose related adjustments in the heparin. We also know that it's going to affect their PTT, and it's going to have a variable effect on their PTT. And the question comes in is, why is it hard to regulate? Why is there such a variability in their PTT? And the answer is because if you look at heparin, all right, and this is the initial heparin that we've given, the molecular weight varies within that heparin solution. So instead of it all being a uniform molecular weight size, it varies. All right, so it can range anywhere from 5 to 30,000 Daltons in the sense of its weight. And because of that variations within these unfractionated heparin solutions, you're going to have a variability of which of the molecules are actually working, all right, which ones are anticoagulating, which ones are not working. So you get a very variable response in your patients. If you look at heparin, all right, giving heparin as an anticoagulant in some of these patients, then we also think about bleeding as being a very common side effect in heparin, actually probably even more than the Coumadin. And another really big issue on putting somebody on heparin is that they are also prone or at risk for going into what's called heparin-induced thrombocytopenia, and we abbreviate that HITS, heparin-induced thrombocytopenia. And with that, it is basically the heparin interacts with the patient's immune system to start to bind the platelets. And so what you'll see when somebody has the HITS, and that is within 24 hours, you see a significant drop in their platelets. And we'll see this somewhere after 7, maybe 10 days the patient's been on the heparin. We'll actually see this very quick drop in their platelet count. So at one time their platelet count maybe 250,000, and in 24 hours we're at 50,000. All right, so it's a significant drop in their platelet count for no other known reason. All right, we'll look back, they're on heparin, they've been on heparin for about a week, then we think about them being a high risk for the development of the HITS. Other risk factors or side effects of heparin is osteoporosis, alopecia, hypersensitivities, hypoaldosteronism, but again the big one is probably more of the bleeding risks and the HITS risk. We also can look at low molecular weight heparins, and again what makes those more consistent, the reason we don't even have to really monitor drug levels on these patients or coagulation studies on these patients, is because again it's a very consistent molecular weight, and that's what we call a low molecular weight heparin. So it has a higher bioavailability, so all of these molecules are now readily available for work as an anticoagulant versus the variability we see with the unfractionated heparin. The low molecular weight heparins have longer half-lives. So again, they're a parenteral route. We do it through the sub-Q administration. It's a parenteral route, but it has a longer half-life. So we can now do, instead of like heparin 3 times a day, we're looking at low molecular weight heparins once a day or twice a day. It's more predictable, has lower bleeding complications, and has fewer interactions with platelets. It is very rare for low molecular weight heparins to develop HITS. All right, we see the HITS syndrome more in the heparin than we do with the low molecular weight heparins. And a little bit again on warfarin, like I said, we've talked about the studies on the use of it, but now let's kind of look a little bit about the drug itself. Again, warfarin is your oral anticoagulant. It is a vitamin K antagonist, so if they have a high dose of their warfarin and they are increasing their INR, then we can actually reverse that with vitamin K. So vitamin K would be your antagonist. So somebody may have a bleeding complication from the warfarin. How does it work? Well, what warfarin does, it's going to interfere with the production of your vitamin K dependent proteins. That's like factor 2, factor 7, factor 9, and factor 10. So it interferes again with the factors within the clotting cascade, and that's what interferes with the ability to form a clot. The dose range of warfarin is anywhere from 2 to 10 milligrams per day. And again, you're going to be monitoring their PT with the INR, and they're going to monitor it at least until it's stabilized. And so we look at a month, if not more. And like I said, that's what we did in home health. Once you get them home, you start going out and you monitor their INRs, and you actually try to get everything to stabilize. Again, most common side effect is bleeding, and it interacts with all these other agents. Other adverse effects, we can see skin necrosis, which is very uncommon. But most of the time, like I said, it's this INR trying to regulate it with a higher bleed risk. So anticoagulation therapy overall. Let's look at the intercerebral bleed risks. We talked about anything over 4 as an INR can significantly increase your risk of a bleed. But let's take a look at some of the studies that did actually look at bleed risks. And what they found is an INR between 2.5 to 4.5 increase intracranial hemorrhages by 7 to 10 times a year. But now keep in mind, when you look at that study, they combine the whole range in there. And we already said over 4 increases the risk. So you've got to really be able to break out anything that's over 4 to see what the actual risks of their cerebral hemorrhages. There was a study called SPIRIT that found the absolute rate intracerebral hemorrhage was about 3% per year in a patient that was anticoagulated. And again, mortality rates in those patients exceeded 50%. Okay, so if they do have a cerebral hemorrhage, it is considered to be a significant complication and carries with it a very high mortality. So again, that's the risk-benefit that we've talked about throughout the lecture. What increases somebody's intracerebral hemorrhage risk besides just being on an anticoagulant? Can be hypertension. Right? The higher the blood pressure when somebody's anticoagulated, the greater the risk. So if you put somebody on anticoagulation therapy, then we also have to think about monitoring blood pressures. And if they have a chronic hypertension or a history of, then we want to make sure that they're also on their antihypertensives. Again, good patient education. Let them know what the combination between the two can result in the way of a complication. If they have a prior ischemic stroke, and we talked about that in the earlier module, this is the transformation. If you have an area of infarct that the tissue's dead, it's irreversibly injured, then it can readily convert or transform from an ischemic infarct to a hemorrhagic stroke. Over the age of 75, which we've addressed, white matter abnormalities and microbleeds or microhemorrhages. All of those can increase the risk of intracerebral hemorrhages on anticoagulate patients. If they do bleed, like we talked about, in Coumadin, you have to think about what your reversing agents are. And what are you going to do? If a patient that's anticoagulated presents with a sudden neurological deficit, again, the original process is to get a CT scan. Let's take a look. Are we dealing with a reoccurring cardioembolic stroke, or are we dealing with a hemorrhagic stroke as a complication of their anticoagulation therapy? If they're bleeding, all right, they've got a hemorrhagic stroke, then of course we stop the medications. We no longer administer any of their anticoagulants. We look to make sure we know what everything else they're on, because sometimes they are on other drugs that have side effects of anticoagulation. And then if it's like the Coumadin, we're going to give them vitamin K. Keep in mind, though, that vitamin K is not an immediate reaction, so don't keep giving them a bunch of vitamin K, because you can actually reverse their ability to clot. So you don't want to keep giving it to them. You give it to them initially up front. Give it time to work. If the patient is bleeding or continuing to bleed or is a high risk for a rebleed, then at that time we can also give them FFP, or we can give them cryoprecipitate. And cryoprecipitate gives them back some of their clotting factors. All right, so FFP and cryoprecipitate is going to do that. Now keep in mind, again, it may require a relatively large amount of these transfusions to be able to reverse their bleeding complications. One of the newer therapies that is being looked at in a patient that has a bleeding complication from being anticoagulated is the recombinant activated factor 7. This has been used now with trauma for a while. If you have a trauma patient that comes in, they're bleeding, they've gone into a coagulopathy, then we've shown that that recombinant activated factor 7 can reverse their bleeding situation, their coagulopathy. So that's what they're looking at now in stroke patients that have the complications of the intracerebral bleeds following their anticoagulation therapy. There's been some studies that have shown some significant benefit of using the activated factor 7. Another big area that we get into in the sense of debates and controversy and needing a little bit more study on is once they've bled. All right, let's say again you've got a patient who's atrial fib, who may have even had a thrombotic stroke a year ago. They now have been anticoagulated and they bleed. Patient's hospitalized, and now the physicians are debating when do we put them back on their anticoagulation therapy, because you still have this risk benefit that you have to look at. If we keep them off the anticoagulation therapy, they have the risk of having a a second or a reoccurring cardioembolic stroke. If we put them back on their anticoagulation therapy, then they have a risk of a rebleed, especially since they've already bled once. All right? So it becomes this risk versus benefit. And really it becomes very individualized. So there's not a very good standard right now or a recommendation or guidelines. It just becomes very individualized, that we look at the patient, we look at their risk for the actual cardioembolic strokes, and we look at the size of their bleed, we look at their blood pressure, we look at their risk for having another hemorrhagic stroke. And based on the individualized, then they decide when to start back up on their therapy. Some of the studies, if they have any recommendation, what it says is if absolutely necessary, meaning that if the risk for having an embolic stroke is high, then the resumption or starting back on these anticoagulants can be 1 to 2 weeks after the intercerebral hemorrhage at that point in time. And they've shown that that can be associated with a very low short-term risk of embolization and no major complications. That's 1 to 2 weeks out. We have a lot of physicians that debate starting it even earlier. But they do say that if you have to, and again, it's not recommending that you do it, it just states if you have to, then they can start them back on their anticoagulation therapy within 1 to 2 weeks. And it's relatively safe. So the other option then we have in atrial fib patients is if we have somebody in atrial fib, we can either just anticoagulate them, prevent the clots, from forming so that we don't have cardioembolic strokes. Or the other thought is why don't they attempt to reverse the atrial fib, treat the atrial fib, put them back in a normal sinus rhythm, which would also then reduce the risk of a cardioembolic stroke. So this, if you look at the study that was looking at just reversal of atrial fib and its effect on preventing strokes, it was the AFFIRM study that's been done. It randomized patients to either a rhythm or rate controlled group. Rhythm controlled meaning they're going to attempt to reverse the atrial fib and put them back into normal sinus rhythm. The rhythm control was done with cardioversion and also was done with medications to try to reverse the atrial fib. And what they found is that there was no significant differences in mortality or incidences of strokes. The highest risk of anybody having a cardioembolic stroke were still the patients who had persistent continual atrial fib despite the interventions of trying to reverse it. The highest risk, though, of cardioversion is that they can when they cardiovert them, then it may actually throw a thrombus or an emboli into the cerebral circulation. And what they found is that even though you do echocardiograms, even though they may do transesophageal echocardiograms, they may look at that echo and say, there's no thrombus in there, there's no clot in that left atrium, so let's cardiovert them. There could have been a small clot that was actually not visualized on the echo, and it can still be thrown systemically into the cerebral circulation as an emboli. So it's not a 100% guarantee, but it is highly recommended that we do echoes prior to doing a cardioversion to reverse the atrial fib. They also in this study found that there's an increased risk of throwing these little emboli after cardioversion, even up to 72 hours after when they cardioverted them. So again, the big thing is if you do want to anticoagulate and do that, they do recommend that we do systemic anticoagulation on the patient prior to, and they also do the echocardiograms prior to doing the cardioversion. So oral anticoagulation can be used, like the Coumadin, putting the INR at about 2.5 for 3 weeks prior to, or even maybe 4 weeks prior to the cardioversion. Perform the transesophageal echoes, and then if there's no thrombi present, then they can do the cardioversion. They also recommend anticoagulation therapy continuing until the normal sinus rhythm has been maintained for at least 4 weeks after the cardioversion. Because again, we'll see patients will cardiovert from their atrial fib, and then they'll go back, into atrial fib several weeks later. So that's another way of managing patients with atrial fib and trying to prevent the cardioembolic strokes is with the cardioversion. All right. So we've looked at cardioembolic strokes, we looked at the risks, we looked at the benefits of managing them with anticoagulation therapy, looked at recommendations of using warfarin, talked some about aspirin in low-risk patients. We've also looked at actually cardioverting our atrial fib patients. So I thank you very much for being with me today on the cardioembolic strokes.